Hello everyone, myself is Dr. Tejas Patel. In this session, we'll discuss about assessment of adverse drug reactions. Learning objectives of this session are: you should be able to understand causality assessment, that means how likely that drug is the cause of reaction in this particular patient. And second objective is which adverse drug event or reaction is considered serious. So what is the importance of causality assessment? Why we require causality assessment for drug adverse drug reaction pair? The first reason is adverse events are not always specific for the drug, as one drug can cause different types of adverse drug reactions based on its pharmacological property or characteristics of the patient. Similarly, one adverse drug reaction can caused by different types of the drugs. Second important thing is diagnostic tests are usually absent except for use of skin patches or intradermal testing to identify allergen in case of few cases. Intradermal testing is mainly used for penicillin G and neuromuscular blockers. Otherwise, diagnostic tests are usually absent. So in practice, few adverse drug reactions are certain or unlikely. Most are somewhere in between these extremes. There are many causality assessment methods, but the most commonly used one is which is proposed by WHO. So in this session, we'll discuss about WHO causality assessment method. This causality assessment method categorizes the drug ADR pair into 6 different categories. One of the 6 different categories. The first category is certain, next is probable, possible, unlikely, unclassified, or unclassifiable. And this causality assessment requires the following information to categorize drug ADR pair. These are time relationship, so starting of the drug and development of the adverse drug reactions, pharmacological properties of the drugs, that is in case of augmented reaction. This is not applied in case of bizarre type of reactions. Likelihood or exclusion of other causes like concomitant drugs and underlying disease. De-challenge, that means withdrawal of a drug and improvement in reaction. Re-challenge means reintroduction of suspected drugs and whether adverse drug reaction reappeared or not. So these criteria are same that we discussed for the how to detect adverse drug reactions. Now we'll discuss first category, that is of certain. So, any adverse event or laboratory test abnormality with plausible time relationship to drug intact, which cannot be explained by disease or other drugs, event definitive pharmacologically or phenomenologically, response to drug withdrawal plausible, and re-challenge is positive. So if we do not go into word jargons and understand it simply, any adverse drug event which has a strong temporal relationship between the intake of drug and development of adverse drug reaction, which can be explained by the pharmacological properties of the drugs in case of augmented type of the reactions. There is no any alternative explanation. That means only single drug is suspected. Concomitant drugs are ruled out. There is no possibility of adverse event due to underlying disease. Then de-challenge should be positive. That means reaction subsides on drug withdrawal. Re-challenge should be positive. That means reaction reappear when the drug is reintroduced. We will understand with the one example. A 30-year-old woman was on category 1 DOTS containing isoniazid, rifampicin, pyrazinamide, ethambutol and vitamin B complex for pulmonary tuberculosis. After 1 month of starting treatment, she developed hepatitis. SGPT was 500 international unit. Viral markers for hepatitis were negative. The physician suspected isoniazid, rifampicin and pyrazinamide as a cause and stopped them because they are the hepatotoxic drugs. After 1 week, hepatitis improved and gradual reintroduction of suspected drugs were planned. So first rifampicin was reintroduced and hepatitis did not develop. That means rifampicin was ruled out. After 1 week, isoniazid was reintroduced and hepatitis did not develop. That means isoniazid was also ruled out as a suspected drug. In next week, pyrazinamide was reintroduced and patient developed hepatitis. SGPT was 400 international unit. We will do its causality assessment. So here in this case, there is a strong temporal relationship between the starting of pyrazinamide and development of the hepatitis. Then hepatitis is knownly caused by the pyrazinamide. Pyrazinamide is known to cause hepatotoxicity. So it explained from its pharmacological property. There is no alternative explanation because viral markers for hepatitis were negative, as well as reintroduction with isoniazid and rifampicin were negative. D challenge was positive. That means withdrawal of pyrazinamide improves the hepatitis. Re challenge was also positive. Reintroduction of pyrazinamide causes reappearance of the hepatitis. So that means based on all this information, we can say causality association between pyrazinamide and hepatitis is of certain category as per the WHO causality assessment scale. Next category is of probable category. So any adverse event or laboratory test abnormality with reasonable time relationship to drug intake, unlikely to be attributable to disease or other drugs, response to withdrawal clinically reasonable, re-challenge not necessary for this category. And if you understand simply, there is a temporal relationship between the starting of drug and development of ADR. It should be explained by pharmacological property of the drugs in case of type A reactions. It is not applicable in case of type B reactions. There should not be any alternative explanation. That means only one drug is suspected and no possibility of underlying disease to cause adverse drug event. Then D challenge should be positive. So patient improves after withdrawal of medication, but here re-challenge is not performed. So only difference between certain and probable category is of reintroduction of the drugs. We will understand with one example. A 60 years old man was prescribed tablet prazosin 0.5 mg orally BD and tablet finasteride 5 mg orally OD for 15 days for benign hypertrophy of prostate. That means two drugs were prescribed, prazosin and finasteride. On next visit, patient complains of having frequent episodes of dizziness and fainting, which suggestive of postural hypotension during last 15 days. Patient was asked to take tamsulosin orally OD in place of tablet prazosin and continue the tablet finasteride as it is. That means prazosin was suspected as a causative agent. On next visit after 15 days, patient was better and advised to continue tamsulosin and finasteride. So we will do the causality assessment for prazosin induced postural hypotension. So temporal relationship is present. Postural hypotension developed after starting the prazosin. Prazosin also explain postural hypotension because it's an alpha-1 blocker, it's a vasodilator, so it can cause postural hypotension. Here there is no any alternative explanation because other concomitant drug, that is finasteride, is a 5-alpha reductase inhibitor which blocks conversion of dihydrotestosterone to testosterone and retards the progression of BPH. It has no vasodilatory property, so it cannot cause postural hypotension. Similarly, BPH can also does not cause postural hypotension. Here D challenge was positive. That means postural hypotension improves after the stoppage of prazosin. However, prazosin was not reintroduced. That means re-challenge was not performed. So now we can say the association between prazosin and postural hypotension is of probable category as per WHO causality assessment scale. Third category is of possible. So any adverse event or laboratory test abnormality with reasonable time relationship to drug intake. Could also be explained by disease or other drugs. Information on drug withdrawal lacking or unclear. That means either suspected drug was not withdrawn, for example in case of mild reactions, or outcome of the drug withdrawal was not clear because either multiple drugs were suspected or patient was lost to follow-up. So if you compare all of these category and understand it simply, to categorize as possible category, there should be a reasonable temporal relationship between the starting of the drug and development of ADR. Then it should be explained by the pharmacological properties of a drug in case of augmented type of reaction. But there could be a alternative explanation by underlying disease or concomitant drugs. For example, patient of migraine has received ibuprofen and he got vomiting. So we know that ibuprofen can also cause vomiting as well as migraine can also cause vomiting. So in this scenario we could not differentiate whether the vomiting could be due to migraine or could be due to ibuprofen like NSAIDs. Then de-challenge criteria is not applicable. Similarly, re-challenge criteria. We'll understand it with the example. Previously we discussed the same example. A 30-year-old woman was on category 1 DOTS receiving isoniazid, rifampicin, pyrazinamide, ethambutol and B complex. After 1 month she developed hepatitis. Physician stopped isoniazid, rifampicin and pyrazinamide. After 1 week hepatitis improved, but patient did not come back for the re-challenge. So that much information is available. Now we will do the causality assessment. We don't know the subsequent outcome. So causality assessment for antitubercular drugs. So there was a reasonable temporal relationship between the starting of antitubercular drugs and development of hepatitis. Patient was receiving known hepatotoxic drugs like isoniazid, rifampicin and pyrazinamide. So it is explained by its pharmacological properties. But here alternative explanation is present because multiple drugs are suspected. So for isoniazid, alternative explanation is rifampicin and pyrazinamide. Similarly for pyrazinamide, alternative explanations are isoniazid and rifampicin. Here is also viral markers for hepatitis were also not performed. So that could also be possibility of viral hepatitis. Yes, de-challenge was positive, but it's positive for all the 3 drugs. So it is inconclusive. That cannot pinpoint whether suspected drug was isoniazid, rifampicin or pyrazinamide. We cannot say the improvement occurs because of the withdrawal of either isoniazid or rifampicin or pyrazinamide because they were simultaneously withdrawn. Here reintroduction not done. So based on all this information, causality is possible for isoniazid, rifampicin and pyrazinamide. Here all the 3 drugs are suspected. Now, unlikely causality. Any adverse event or laboratory test abnormality with time to drug intake that makes a relationship improbable. So there is no reasonable time relationship, or disease or other drugs provide plausible explanation. That means alternative explanations are strong. So for the in unlikely category, temporal relationship is not likely. There is strong alternative explanation. So in a previous case of pyrazinamide induced hepatitis, now after reintroduction, rifampicin re-challenge hepatitis did not develop with rifampicin. Similarly, after reintroduction of isoniazid, patient did not develop hepatitis. So causality is unlikely for rifampicin and isoniazid, as re-challenge with pyrazinamide was positive. So it strongly explains the hepatitis in case of in this scenario. So causality is unlikely for rifampicin and isoniazid. Next category is unclassified. any adverse event or laboratory test abnormality where more data for proper assessment are needed or additional data under examination. We understand it with one simple example. A 30-year-old male patient come to dermatology with severe itching and generalized maculopapular rash. On detailed history, he was taking some over-the-counter medications for common cold since last 3 days, but patient did not bring these medications with him. The dermatologist asked him to stop all OTC drugs and bring them on next visit after 3 days. He treated the patient with antihistamines and steroids. So here the exact nature of the suspected drugs are not known, which over-the-counter medications patient took. So more data are required for the assessment. So in this case, causality is unclassified. The last category is unclassifiable. A report suggesting an adverse reaction cannot be judged because of insufficient or contradictory information, or report cannot be supplemented or verified. So in a previous case of over-the-counter medications induce severe itching and generalized maculopapular rash, dermatologist asked him to bring all these OTC drugs on next visit. So on next visit, patient improved, but he did not bring medications as they were misplaced. The dermatologist advised the patient not to take OTC medications and kept the record of all future use of medications. So here data is not verified because patient has misplaced the OTC medications. So causality is now unclassifiable. In the next part of session, we'll discuss about which adverse event or reaction is considered serious as per the International Conference on Harmonization guidelines. So any adverse event or any untoward medical occurrence that at any dose results in death, is life-threatening, requires inpatient hospitalization, or results in prolongation of existing hospitalization, results in persistent or significant disability or incapacity, is a congenital anomaly or birth defect. Any adverse event is a medically important event, may require medical or surgical intervention. So, life-threatening reaction means patient is at risk of death from the reaction. So there is an immediate risk of death. Examples of life-threatening reactions are severe hypotension, unconsciousness, etc. Then hospitalization means admission to hospital for longer than 24 hours. So at least 1 day hospitalization or prolongation of a existing hospitalization in case of inpatients. Then disability means there is a substantial disruption of a patient's ability to conduct normal life functions. Examples of disability are paralysis, hearing or vision defect, loss of speech, loss of memory, or even a weakness or fatigue, if so great the patient cannot get out of bed at all. So any condition which makes the patient bedridden can also be considered as a disability and considered serious reaction. Then exposure to a medicine prior to conception or during pregnancy resulting in fetal malformations, so considered as a teratogenicity or congenital anomaly. Examples of congenital anomalies are neural tube defect, cleft palate. And lastly, medically important event may require medical or surgical intervention. So all those important adverse events that may not result in death or a life-threatening or require hospitalization, but they may jeopardize the patient and may require medical or surgical intervention to prevent death, life-threatening reaction or hospitalization. Examples include bronchial asthma, requiring intensive treatment in casualty or emergency room or at home, which does not require hospitalization. Then convulsions, they do not result in hospitalization. Blood dyscrasias like thrombocytopenia, leukopenia or aplastic anemia. Then development of drug dependency or drug abuse also comes under this category. We'll understand with some examples. A case of NSAIDs-induced gastritis. A 30-year-old male patient was prescribed ibuprofen, diclofenac for 15 days at an outpatient clinic for osteoarthritis. Now, on next visit, patient reported improvement in knee pain, but he also reported gastritis, that is burning feeling in stomach, abdominal pain and bloating. So, tablet ibuprofen and diclofenac were stopped. Patient was asked to take tablet paracetamol as and when required for knee pain. He was also prescribed tablet famotidine 40 mg PD for 7 days for gastritis. Is this ADR serious? So, this is an example of non-serious reaction as patient managed on OPD basis with withdrawal of medications, that is withdrawal of ibuprofen and diclofenac, and gastritis was treated with the gastric acid reducing agents like famotidine. If such patients develop peptic ulcer with signs of active bleeding, then it can come under medically important event that may require some intervention. Otherwise, gastritis is considered as a non-serious reaction. Next case of Stevens-Johnson syndrome. So, 18-year-old girl presented to emergency department with fever, unable to take oral food and widespread blisters. So, on examination, she found febrile, blistered skin lesions, eye, oral and genital mucosal ulcerations, and she was diagnosed to have Stevens-Johnson syndrome and admitted in ICU. So, here patients require admission in intensive care unit. So, that means it requires hospitalization. So, this ADR is considered serious. Now, case of the antitubercular drug induced hepatitis. A 30-year-old woman on category 1 DOTS developed hepatitis after 1 month. SGPT level was 500 international unit. Right. In this case of hepatitis, the reaction was not life-threatening. The patient does not require hospitalization, but the SGPT level is 500 international unit. Upper level of normal limit for SGPT is 40 international unit. Now, rise in SGPT level of more than 10 times the upper normal limit is considered as severe hepatotoxicity. So, the upper limit for the severe hepatotoxicity is now 400 international unit and patient got 500 international unit. So, this is an example of serious reaction which comes under the category of medically important event which may require intervention to prevent impairment. If the SGPT level was less than 10 times of the normal limit, then it would categorize as a non-serious reaction. Thank you.